Welcome and thank you for joining. My name is Melanie Bentoncourt and I'm a health educator for community health at Atlantic Health System. Today's webinar, Intimate Partner Violence in the Deaf Community, is presented by Courtney Rosenborough she does vulnerable populations as a senior program manager, and Ali Matheson from the Deaf Services Program as a manager. Our ASL interpreters is Kristen Steinmetz and L'Oreal Jacobs Martinez. They are from the DASAC of Warren County. Before we begin, I have a few announcements. The webinar is being recorded and all participants are muted. If you have a question, please use the Q&A button and use the chat feature for comments. We will try to get through all the questions at the end of the presentation. Are you or a loved one interested in smoking cessation? Atlantic Health System offers a free quit smoking program. This program includes an individual assessment, free nicotine replacement products, and 6 weekly group meetings to help you quit and stay smoke-free. There are multiple dates and times available, with groups available in person or virtually. For more information about these groups and other resources, or for additional dates and times, please call 1-844-472-8499. Now I'm going to turn it over to Courtney and Ali and our interpreters.
Okay, give me 1 second and I will pull up our PowerPoint. Okay. So Ali is going to take the first slide. I will take the next 2, and then Ali will handle the rest of the presentation.
Hello, everybody. This month is Domestic Violence Awareness Month. And so, it's a really important topic. And this is about intimate partner violence in the deaf community and what that looks like. So I am the Deaf Program Service Coordinator, the Program Manager for DASAC, and I'm excited to be presenting about this topic today. Courtney's going to expand a little bit on IPV, what that looks like, and on DASAC services specifically, and what they have to offer.
Okay, so just to lay some foundation before Ali gets into the topic, we'd like to share what the Domestic Abuse and Sexual Assault Crisis Center, known for short as DASAC, what we do. So everything we offer is free and confidential. We run an emergency shelter for those in imminent danger. We run a 24/7 hotline and web chat where we provide advocacy and safety planning. We also take intakes to sign survivors and victims up for counseling, whether that's individual or group, and that would include children's counseling as well. Ali provides deaf advocacy services in American Sign Language. We have a bilingual advocacy and outreach program for the Spanish-speaking population. We operate a vulnerable populations program to serve the needs of older adults and those with disabilities. And then we do crisis response. So we show up to hospitals for sexual assault cases, and we show up to police stations for domestic violence cases, where we offer on-site advocacy, safety planning, and coordination of care for DASAC services. And we also offer long-term case management, which could include financial empowerment, housing assistance, or other needs. To lay a foundation and define what intimate partner violence is, it's a public health issue with serious economic and long-term health impacts on survivors and victims. IPV costs the United States billions of dollars annually, and on an individual level, it can cause financial catastrophe. IPV can be one incident in a relationship, or it can be chronic. It could be multiple incidents over a length of a relationship. It can look like physical, emotional, sexual violence. It can look like stalking, aggression, or financial abuse. Almost half of women experience IPV in their lifetimes, and a quarter of men will experience IPV in their lifetimes. For the trans and LGBTQIA+ population, they are at higher risk of IPV. IPV often starts in adolescence, and again, marginalized individuals from underserved communities are at the highest risk of intimate partner violence and all forms of violence.
All right, thank you very much. Now I'm going to focus specifically on marginalized community and specifically the deaf community. And I'm going to touch on a lot of these systems, but specifically on how deafness is a spectrum. And I'm going to look at the power and control wheel as well. I'm also going to talk about recommendations for providers with safety planning. We're going to discuss community accountability and some guidelines for the health provider, as well as providing some resources. So here is a video that I'm going to show you now. It's only 3 minutes long, and it's going to give you a little bit of background information regarding the power and control wheel. And it doesn't, and also shows you specifically how not all deaf people are the same. So let's go to the video because it does have sound and closed captioning as well. And we'll show you the spectrum within the deaf community.
I will play the video. Just give me a second to pull it up. Unfortunately, we couldn't embed it into our presentation.
Deafness is a spectrum. It's not just one definition. Someone like myself who's late deafened.
I am deaf in one ear and hearing in the other. Some people view me as a deaf person, some view me as hearing, but it's not one or the other.
I was born deaf. My father is deaf in one ear, so it's hereditary.
I'm the youngest of 5 siblings. The 3 youngest are deafblind.
I switch between deaf and disabled because I'm also a little person.
Being deaf is a big part of who I am, but that's not my only identity. I'm a person of color, biracial, half black and half white, and gay.
This is the condition I have. It's called Usher syndrome. It's a hearing and vision loss.
I grew up oral.
A lot of people consider me hard of hearing.
People do call me hearing impaired, but I'm not. I'm deaf.
People think being deaf is a bad thing, but I see it as a positive thing. The culture, language, and history make me who I am today.
The deafblind community, tactile ASL, the use of space, the culture, all became a part of it.
I'm learning little by little about Protactile and I can't wait to learn more. I am most comfortable with speaking English.
People with additional disabilities have to think about access and what they want. Do they know what they need?
Throughout educational years, I used note takers. I didn't have interpreters because I didn't know sign language. I didn't know ASL until I was 14.
I used cued speech and was mainstreamed throughout high school.
I went to a public school in the morning, then a deaf school in the afternoon. It was the best of both worlds. The instructors used ASL, which I found to be more inclusive.
I was in both deaf and hearing classes. I wore that bilateral hearing aid cinched across my chest. Very unpleasant.
I got a cochlear implant when I was 15 and went through intensive speech therapy.
In high school, I would sit to the far right, since I could hear on my left side.
In large group discussions where there's dynamic conversation, I use interpreters.
In my own experience, captioning and interpreting together are the most effective.
I want more of a long-term designated interpreter. Someone who knows me well, who knows my work.
As a Black person, I want my interpreter's voice to match me. My culture can't be overlooked.
People automatically think deaf people are all the same, but that's not true. We have layers upon layers.
When you meet us, have an open mind and open heart.
Thanks so much for that. So that videotape, when you watch that, you can see how,
Deaf,
lacking
the power of hearing, or having impaired hearing. Unwilling or unable to hear, or pay attention to something.
looks like it was running on. I'm sorry about that.
Is that me? That was me. Sorry, the video continued.
Okay, so with this video, I just want you to notice, that this common themes that continue to pop up about educational background, about identity, about how people picked up language and when they did in their lives, ASL specifically, how it's such a great variety in educational journeys for different deaf individuals. Some people become late deafened later in life. Some people are genetically deaf through family, and it's inherited deafness. So it's a wide range, and it's a common misconception that people think that everybody in the deaf community is the same, but they're certainly not. Every individual has different experiences and has different needs. There's people who are deaf blind, people who are hard of deaf and or just consider themselves hard of hearing, people who are deaf and have other disabilities as well. So it's important to recognize that. Let's look at the next slide. So something I really want to emphasize is language deprivation and what it actually means. So it means missing that opportunity to acquire language during that really crucial time of a child's life from birth to 5 years old, and how the exposure to language is really not there for some children, and they don't have it either in spoken or in signed language. That 92% of deaf children are born to hearing parents, and frequently when that child is born, and that is the very first deaf person that those parents have ever met in their life. So it's really important to recognize that they don't have the background knowledge, they don't have the language, they don't have the culture or any understanding of what it means to be a deaf person, and suddenly they have a deaf child. So a lot of times they deal with whatever they're told by the medical professionals. And the medical perspective really is to give a child hearing aids or a cochlear implant, to do something that makes them more hearing. What's really important is just to emphasize language, to make sure that that child actually during that crucial learning time has access to language and exposure to it. So, parents, they want their children to match them, but a child doesn't have the ability to match their parents. It's important for the parents to recognize what they need to do to match the needs of their child. We're going to be switching interpreters.
So then we're talking about 90% of deaf children that really have no accessibility to language, to sign language, to the proper education in the beginning of their lives. And that really impacts them forever. It causes a lot of issues. Health issues come up, mental health issues. They miss so much information in that crucial time. So there winds up being a giant gap in learning. So we have 3 out of 4 parents that do not sign with their deaf child. So often what happens at the dinner table, there's conversation with the family about their day, talking about like what's happening, the chores, the world, the community, and all that incidental information is missed if your parents aren't speaking your language. How about in the car? And hearing person in the car would have the radio on. They could hear what's going on. They have information access while they're doing something else. But deaf people don't have access to that language that's happening around us all the time. So there's a language delay. It leads to a reading and writing delay. It leads to social issues. It impacts so many parts of these kids' lives as they grow. So it's really important that we give them the exposure to ASL and spoken language, whatever that kid needs in that crucial time. And other things that we want to mention. I know recently the hospitals started to do some kind of hearing screening. So, I mean, it's had been happening forever. Like they've been doing it with babies. I think it was like 1999. They said it was started to be required. So an infant was born, they'd do a hearing test so that the parents would know right away, like if there was something going on with the hearing. So for example, when I was born, my parents didn't find out I was deaf until I was 10 months old. So that's way later. That's a loss of 10 months of just not having access to language. So now it's nice that we have the early intervention and figuring out earlier that babies are deaf. And it encourages the doctors, the speech therapists to kind of step in early, but they don't have access to ASL and deaf people and all the options for these children. So it depends on who's speaking with the children at that time, the options are given. So Courtney was mentioning about intimate domestic partner violence and how it can be higher in oppressed communities. So yes, I think that 150% more chance for a deaf individual to be a victim of assault, abuse, or bullying in their whole lifetime. So often what happens, there's barriers to receiving services. So if they experience that again and again, we'll talk more about that later, what that looks like. It can impede them from getting help. So I want to explain now about this power wheel and about having this deprivation of language and how it kind of leads to this power struggle through their life. So let's say we have a deaf person. Maybe they're more visual. So it would be like maybe a deaf of deaf.
Deaf Hope Agency in California invented this wheel to make it more visual for the deaf community.
So about 20 years that program's been running. So they've been collecting a lot of data and have had a lot of experience of deaf consumers and individuals. So they were able to really make this wheel relevant to real life. So it's really important for the deaf community because I want to explain this. I want to show you just a few examples. I mean, there's always things that are going to pop up that are like outside of our realm of understanding, but in general, we'll talk about it right now. So one part of the wheel is intimidation. So in deaf culture, the appropriate way to get somebody's attention if they're deaf, it's like knock them on the shoulder very lightly, maybe on the table, a little tap, a little wave, maybe a light on and off, like subtle ways to just get somebody's attention. But if there's a power control thing happening in this relationship, the abuser might slam really hard on the table, be really aggressive about that movement. Maybe the door they'll slam. So they're trying to get their attention, but it's very aggressive. Maybe they'll get right in their face to sign, very close to them, and be in their personal space. That's not typical. That's really an anger and a control reaction. Okay. Using emotional abuse. So it depends. It goes back to having certain educational backgrounds. So domestic violence with a partner, it depends on if the other partner is deaf, the other partner is hearing. Maybe one of them is hard of hearing. There's deaf blindness. So these differences in the disability could affect the power struggle and who has control in the relationship. There could be bullying and teasing. There could be different levels of skills for reading and writing. So it's something that someone can kind of make them feel superior over the other person. Like they're looking down on their partner for their educational background. Next slide. Using isolation. Maybe they're checking each other's phones. Maybe the VP, the video phone relay service that people use, that's a deaf technology that's very common. Maybe they're looking and seeing who they're talking to during the day, going back into the phone log. And then the abuser might take advantage of that situation and try to isolate that person and give them no access to resources and no access to people that can help them. Next. Minimizing, denying, and blaming. The abuser might think like, this is nothing, this isn't abuse, and just kind of gaslight the person into thinking that it's just part of deaf culture, or maybe, you know, talking rough, it's just the way my voice is, or touching rough, that's normal. Throwing things could be something that they say, oh, in the deaf community, sometimes we want to get people's attention. So, you know, maybe you throw something their way, but it can be done aggressively. Using the children in the situation. So if there is a hearing partner, maybe they're telling the child not to use ASL. Maybe they're telling the partner, don't be signing, you know, that's not the language you're using in this house. So we have to keep in mind hearing privilege. Suppose the partner is hearing and they can isolate that person, not clue them into what's happening in a conversation. Maybe they go to the landlord to talk about something. Maybe they go to the bank. Maybe they have a meeting and they're not cluing them in on those discussions and they're just not part of it. Another situation might happen. So maybe a deaf person calls the police. What happens when the police show up and the hearing person takes over the situation? They're speaking English, they're interpreting, so-called, and now they're going to embellish the story to make themselves look better. So the deaf person, if they don't have an interpreter there, they're obviously not in control of that situation. Economic abuse. Maybe taking your SSI checks or reporting the partner, you know, about maybe losing money, and maybe they'll lose their checks from the government if you report them. The deaf community is really small. Maybe they're spreading rumors, getting into people's heads, you know, labeling you a certain way in the community. So that could be a way that they're taking advantage of their partner. another situation might happen. Maybe they're forcing the person to report what they're spending and asking for permission and money in the household. Okay. Force and threats. So a little bit about deaf history.
Hierarchy.
Oh, sorry, hierarchy. So we know that in the deaf community that if someone's well known, if they're deaf, if they're generationally deaf, they're gonna have a name in the community. There's a reputation, there's a power that goes along with that. So here are some recommendations for the providers. I really want to emphasize that you have to ask what their communication preference is. Some people are going to prefer signing. They want ASL. Some people might want English. So it's going to be up to the individual. So it's important you ask them. Keeping open minds and an open heart and being accepting of the deaf culture is important too. Now, there's so many gaps. It's so important for these screenings when we're talking to deaf consumers about domestic violence. So we want to be careful. Sometimes you'll notice doctors and nurses during the screenings for domestic violence and those processes, they'll be asking, you know, is there something happening at home? You know, they'll try to ask a patient, make sure if they're okay, but they have that access to communication. They can have that conversation at the hospital. Sometimes a deaf person doesn't have that. Now, some words, you know, there might be some clinical words, some medical words. They're big words, you know. If there is a language gap, if there's a deprivation of understanding, they're not going to understand those words. So it might not be clear when you're explaining. So for example, slap, punch, kick, threaten, force. Like, we need to be clear about what that means for the person. If that person is missing information, if there's a gap, we have to make sure that we're giving them the resources that they need. If they need a referral to like a deaf counselor or somebody that can sign and understands deaf culture, then that's what we should be trying to provide for them. Next, let's switch interpreters.
So now I just wanted to point out that there are different parts of the community and how the community itself can be more accountable in reducing intimate partner violence within the deaf community. So for example, media, newspapers, advertisements, social media postings, all of those can be accessible to the deaf community if there's closed captioning or if they're signed, but those resources aren't always made accessible for the deaf community. Service providers should know of resources that are available for the deaf community and be ready to provide those resources. The government needs to make sure that lawyers are involved who understand fully the ADA and financially support deaf organizations. And in the workplace, trainings can be done that are about anti-violence and against violence, and also allow for communication access for the deaf community. And in the justice system, police department, courts, Interpreters should be provided for all deaf clients. And there needs to also be an awareness of different deaf clients' needs, especially if they're deaf blind or if they're tactile signers, or if they have, other specific needs, those needs need to be met. The educational system, the curriculum should be ready for any deaf students to be able to have access. Interpreters can be set up and they can confront any kinds of issues that are happening within the deaf community as well. And Hearing Allies can partner with deaf organizations and go out into the deaf community and provide workshops in ASL on various topics. And the hearing people have access to a variety of workshops on a variety of topics. And it's important that the deaf community has access to workshops on those issues as well. I'd like to focus on healthcare for just a minute and on healthcare access for deaf patients. I mean, really generally, healthcare tends to not be accessible for deaf people and deaf patients due to these communication and linguistic difficulties. There's a ton of barriers within healthcare. And the downside of this is it can contribute to poor communication between the patient and the provider. And also, there can be tons of misunderstandings and things can happen that do not meet a person's needs. For example, hospitals are not providing training so that they can match the needs linguistically of deaf patients. And so these are general guidelines for healthcare providers. And you can see all of these. One of them is to clearly identify at-risk individuals for poor communication. So what that means is you need to have a label on the file that says this patient is deaf or this patient uses ASL or whatever their language needs are. And for example, from my personal experience, really is a variety of experience in different hospital situations that I've confronted. But honestly, recently I had an experience where I went in to check on something and I was sitting in the waiting area. I just going for a checkup and there was a different nurse in the department, and one of them hadn't communicated with the other nurse who did know that I was deaf. So they didn't know who's next. At Allie, she was yelling, Allie, Allie's next. And I was just sitting there. I had no idea. People had masks on, so I couldn't read any lips. I had no idea who she was calling or who she was talking to. So I was looking back and forth between the two nurses and nobody stood up. And I thought, well, maybe it's my turn. So these kinds of situations pop up frequently where, you need to make sure that not only one staff member, but all staff members are aware of the needs of the patients who are there in their waiting room. And so it's just some basic awareness. They're very small things, but they make a big difference. Also having visual medical aids. So sometimes somebody's talking, and especially in a medical situation, they might write something down and somebody, the medical language terminology can be fantastically difficult to understand. And so, I think that if they have something visual to reinforce an understanding so that a deaf person can say, oh, wait, what's going on? What's this all about? It can really help clarify things. The providers should know basic sign language, just very rudimentary, just to have the deaf client feel a little bit more comfortable. And also, minimal does not mean that suddenly they're qualified to not have an interpreter and to communicate completely on their own. you need to have somebody who clearly is an effective communicator and is fluent in the language to make sure that the communication is clear. So you need to have a certified interpreter in these situations with a patient to match their needs. And there should be a very clear policy for that. When your interpreter comes in, the interpreter needs to be aware of medical terminology. A lot of agencies tend to, they screen to make sure that they're matching interpreters that are appropriate for the environment. Ineffective communication practices, for example, lip reading. People assume that that's effective, but it really isn't. Sometimes lip reading can cause a tremendous amount of misunderstandings because the words that you see on a person's mouth can look very much like a variety of other words. And if somebody has a mustache or is a mumbly speaker or just very difficult to get some clarity in what they're saying, and so much is in the mouth and the back of their throat, you're not going to understand. That's not clear communication. And masks, of course, in hospitals, there tend to still be masking up, and sometimes they'll bring it down to talk and bring it back up to when they're not, and that's not effective either. Writing back and forth. For some people are impatient with that, and especially creates a tremendous amount of gaps in communication as well. Sometimes the language, again, is of a level beyond the person's ability to understand in terms of their literacy skills. So it's very important to make sure that the language is real communication when it's being written back and forth. So you can see with all of these things, there's a lot of resources related to effective communication approaches, methods. Now, the law, the ADA, American for Disabilities Act, there's some that are very specific to hospital and medical situations, and it's obviously very important to have an interpreter who matches the communication needs of the individual, and that's built into the law.
Specifically Title III.
Specifically Title III, thank you. Other experiences related to requesting somebody for accommodations is to request an interpreter through a healthcare portal. So you do this online and you request an interpreter, you have an appointment, you put that in there as a request, and then they feel like they can just kind of check that off. I've done that, accommodations done, but you need to make it clear that you need an ASL interpreter. And when you send the request, then the patient shows up to the office and that appointment was booked 3 months ahead of time. They show up 3 months later, there's no interpreter there. And they say, oh, look, I request an interpreter, and they can show that they've put the request in, but it's in the system. But the office staff doesn't even know what that means or how to approach that or who they need to contact. So there it is in the system saying your interpreter is required and the request is there, but there's no follow through. And sometimes systems run that way where people in the office staff aren't really aware how they need to contact and bring in an interpreter for an appointment. Leaving a deaf individual without access. VRI, which is a video relay interpreter, is when they use remote interpreting via a large screen or monitor in the office. Sometimes medical facilities will have that, but it can also not be the best fit for the patient for that exact situation. It's better always to have a live interpreter, a person really on site. That's the main priority. With the VRI system, sometimes if, for example, person could be, in something where they're up to their chin and the VRI comes out, the person's in a position where they can't see. Maybe their head
So
can't
maybe
move,
they
or
need stitches on their chin,
or they
and so
need
they
sti-
go into the hospital for that, and they can't adjust to even look at the interpreter.
Exactly. Thank you. Let's go to the next slide. So DASAC is in Warren County, but my services, our deaf services program is statewide for the entire state of New Jersey only, but for the entire state of New Jersey. And there's a few ways that I can be reached, but we do have the hotline, obviously, and that's a 24/7 run hotline. There's also web chat, and that's also available 24/7. You can request an appointment and schedule that with a deaf advocate in American Sign Language. Also, we have a video phone line where somebody can contact during regular business hours, and I can be emailed. The website also, if you go onto our website, the DASAC website, we have videos in American Sign Language that explain all of our services, and all of the information that is in English, in written English, is conveyed in American Sign Language with expansion, so that you can take a look at that anytime you want, get an idea of what that looks like. And there's an English transcript that is connected to each ASL video. Next slide, please. Well, there's also a national US-wide deaf hotline, also 24/7, can be accessed in American Sign Language. And that's the number for that. Next slide. 988, that's the Suicide and Crisis Lifeline. They also have an ASL option. That's very new. That service has just been added. There's also a text option for deaf-blind, and they can connect by using Braille. And the website explains a little bit more about what resources are available as well.
So I just want to sum up some stuff and just leave you with some important points. So whatever we're reporting for domestic violence, you have to understand that it's going to be even more prevalent in the deaf community. So intimate partner violence is going to look different for the deaf community. We have to understand hearing privilege and that oppression and how that's going to work into the domestic violence relationship. A deaf survivor might not feel like they can label themselves as a victim of abuse because, again, we have this language deprivation. So you have to understand all the barriers that keep them from the resources that they might need. So, for example, some agencies for domestic violence, they won't provide interpreters. So there is no communication access there. So that's just an example of one barrier for a survivor. So here's some helpful resources if you want to see more about the power control wheel, about some technology, some mental health providers maybe that sign.
Thank you for joining us. We kindly ask to take a few minutes after today's webinar to complete the program survey. The link to the survey has also been added to the chat for your convenience. A special thank you to Courtney, Allie, and their amazing interpreters for dedicating their time and expertise to today's webinar. If you have any additional questions or comments, please send an email to communityhealth@atlantichealth.org or call 1-844-472-8499. This concludes our webinar. Have a beautiful day, everybody.
Thank you.